Clinical case studies.
One quick question. How often do you find yourself doing a multi-level microdiscectomy, or is that incidence pretty rare?
92% of the time, single level, and 95, and 5% two levels. Pretty rare. So this is a patient and audience participation. You guys are going to go out on the line and scream out answers to me. So this is a 19-year-old who slipped on ice and fell directly on her buttocks and complains of sacral pain. Just think out loud. Okay, sacral pain, is that common for radiculopathy? Yeah, it's a little malaligned there, isn't it? Does that mean, how many people get sacral pain from radiculopathy? Sacrum, the center of the sacrum. 1% maybe? So where's the most logical injury? It's to the sacrum. See the fracture line right through there? So this gal, you can see it right there. Sorry, it is a little dark, but you can see a fracture line right through here and right through here. She fractured her sacrum. You just press on her sacrum and she'll reach around and knock you for a good one. It's pretty obvious, you just have to let it heal. Okay, here's a 27-year-old female. Look at her pain diagram, right? It's pain in the buttocks, lower back buttocks radiating down to the foot. It's a 8 to 10 visual analog scale. 30% low back pain, 70% left lower extremity pain. It's increased with flexion, better with extension. Feels like gait is limited in left lower extremity. Scrunched up sock with tight rubber band feeling underfoot. Hard to go upstairs, which we'll ask the question, what is it? It's what? Herniated disc. Where? So it goes down to the foot, maybe the bottom of the top. So it's going to be an L4-5 or a 5-1 H&P. Simple. Take the history, get your VAS score, and you know what is going on. This is what our AP and lateral x-ray looks like, and it looks normal. No antalgic list, no angular collapse, no slip. So she's got a good-sized disc herniation here on the left at L5-S1, compressing the left S1 root, and she's got calf weakness. So why is she having trouble going upstairs? Not a tension sign. She's got actual, so the calf pushes you up to the next step. If you don't have that, you have to lift your leg higher to get up there. So there's reasons for all these questions. So a 64-year-old, low back pain for a year, was seen 3 years ago with lower low back pain. Now his pain is low and has raised up a little bit. This is not sclerotomal pain, where the intensity of the pain causes referral. So he has more intense pain, and he has impact intolerance and vibration aggravations. Ding, 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 ding. What does that mean? What? IDR. Yes. Can't do typical recreational activities. Pain 3 years ago was controlled with core strength and epidurals. So we had seen him 3 years earlier. So what has happened in 3 years? Well, remember his last one was 5-1. The disc is still narrowed, but you don't see end plate changes, do you? Is there a vertebra or a disc level that you see with end plate changes? Nod your head like this. 3-4, exactly. Look at the end plate fractures, the sclerosis, and the narrowing. So let's go here. This is what his 3-4 disc looked like 3 or 4 years ago. This is what it looks like now. So these things can change in a moment. So you have to be aware what happens. So a 62-year-old ER doc with left anterior thigh pain from skiing about 4 weeks ago. Left anterior thigh pain, what's your differential just automatically? So what nerve? L2 or 3, I mean maybe 1, but L2 or 3. What else can cause anterior thigh pain from skiing? Hip. Don't rule out hip. Hips can do the same thing. It does awaken him at night, you notice. So the hips and radiculopathy can do that. Better with sitting and lying. Well, does that fit with a sciatic neuropathy? No, but what nerve is this? It's the femoral nerve. So the femoral nerve is improved with sitting and worse with an Eli's test or hip extension. So stairs are painful, but in and out of the car is okay. What does that mean? So stairs are painful, could be hip. Getting in and out of the car is typically bad with hips and not bad with radic. He has to lift his left leg by grabbing his pant leg to get in and out of a car. What does that mean? Weakness of what? Psoas, exactly. Crossing of the legs is okay, another hip aggravating factor that's okay. He has a prior L5-S1 microdisc, doesn't mean much. But look at where his pain is so you can get an idea of what's going on. Remember, anything from L1 through S1 will radiate into the buttocks, and then the higher nerves will radiate into the anterior thigh. So here's his x-ray. Reflex and sensory intact. Does that rule out a radiculopathy? No. Why? It's higher than, what's the reflex for the patella? L3 and L4. So if it's higher than that, the reflex is not going to be diminished. Extension reproduces thigh pain. What two things can cause that? Femoral nerve stretch and hip. Log, roll, and grind is tight but not painful, and a negative SLR. Do you expect a negative SLR test? Yes, if it's a higher nerve root, the femoral nerve doesn't get stretched with an SLR. So, lateral x-ray. Significant degeneration of the 5-1 disc. Do we care? No, that's not his complaint. No slips or antalgic positioning. His hip has a little bit of a cam lesion, a little bit of thinning. So what signs would lead you to a hip diagnosis? Pulling his leg up, right? The hip hurts. But that also leads to an L2 or an L3. What signs lead you away? Well, he can cross his legs. He can get in and out of a car. Even though he has to lift his hip, it's not painful. Can the psoas weakness be ascribed to pain inhibition? Yeah, could. So you can't tell. So he has a far lateral disc herniation at L2-3 left. So this is the diagnostic protocol. You take all your evidence and say, what's causing what? These far lateral H&Ps cause symptoms with extension as the foramen becomes narrowed. There is no reflex associated with the L2 root, so DTRs are normal. You can have a radiculopathy without sensory change. It is distinctly possible. And the L2 services the psoas muscle, so the weakness is neurological and not pain inhibition. So it's an L2-3 far lateral. And we just won't spend our time on that. So here's a 62-year-old male with low back pain and his leg drags. So he's got central low back pain, and his main complaint is his leg drags. If you look at his low back pain, does it make you concerned? Look at the number. This is where VAS scores are so valuable. He's a 3 to a 4. So wait, do things start fitting? No, things aren't fitting right. Significant degenerative changes at multiple levels, right? Has low back pain increasing toward the end of the working day. But if you look at the pain diagram, the pain is low. And is that enough pain to have the patient in the office ask him, is your back pain the reason you're here? No, my leg drags. Well, could this be a radiculopathy causing motor weakness without leg pain? We see that, right? You can have a disc herniation without pain. So radiculopathy, there's no evidence of root compression in the canal, but some right L5-S1 foraminal stenosis. Will that cause the leg to drag? Maybe, but that's going to be an L5 radiculopathy, so it's going to be what motor strength weakness? Tibialis anterior and peroneals, right? So that's what you're going to look for. That could be a leg dragging, but most people don't say my leg drags with that. They say my foot flops. It's foot drop. Okay? Whoops, hold on. Patient has no pain radiation with standing. So if you're worried about a foraminal stenosis, a typical foraminal stenotic picture, standing and walking, right? And sitting, it goes away. You're not hearing that from this guy. Occasionally, maybe he catches his foot with walking, maybe, but you're looking at evidence here, and you're not seeing evidence. So, physical exam, he can heel walk bilaterally. He's 5-/5 left tibant, maybe. But wait a second, what does this mean? He's a little hyperreflexic. What about this? What about this? What are you starting to look at when you start to look at an exam? You're starting to say, this doesn't fit with a typical radiculopathy. After the exam, you ask him further questions. You have to start reassessing what you're looking for now. Imbalance for the last 3 to 4 years, maybe difficulty with buttons over the last 5 years, and he had a 5-year ago EMG NCV consult that was negative. So what do you want to do next? Get an MRI of the lumbar spine? Cervical spine. Okay. Well, he has long tract signs. He has long tract signs in one upper extremity. I would say if he didn't have any findings in his upper extremities, I would look at thoracic and lumbar. But because he had findings of Hoffman's, we know it's going to be higher, right? Hoffman's won't be present if you have a thoracic or a lumbar cord problem. So what does he have? See the white spots in his cord? He has MS. Right. This is how you do a diagnosis. You take your information and you try and fit it together and ask these questions. And again, remember Scott William Osler's findings. You see what you know, you find what you look for. If you start to see hyperreflexia, you have to start questioning. This guy didn't have a lot of back pain. He had crappy back syndrome, but he didn't have a lot of back pain. His problem was MS. 17-year-old elite soccer player with left lower back pain. Competitive from England, high-level prospect, left lower back painful symptoms, episodes a couple times over the last couple of years. He does not currently have any right-sided symptoms, but has had right-sided lower back pain in the past. So the right low back pain he had, but now it's gone. Now it's left-sided lower back pain. I'm leading you down a garden path. He had return of pain in September. He had 3 summer soccer camps. He had tried to play a match in January, only able to play about 10, 20 minutes. He's gone through some practices, but he is becoming more and more problematic. Left lower back pain rates is a 5 to 9 over 10. No right-sided symptoms. What do you think? But why right side and then now left side? Exactly. So flexion extensions, you look at that, right? There's no slip, well-preserved disc heights. So you look at that and you go, it's not a discogenic problem. There's no instability. But you look here, this one has an old, starting to progress fracture. This one's complete on the right side. Does the story match now? So the guy had right-sided lower back pain as this was starting to go into a fracture, and then he fractured through it, and what happens when you fracture? Pain goes away. You're no longer stressing the bone, it's free. Now you're stressing the opposite side, and there's his new fracture just starting up. And this is what it looks like, complete fracture here, and this is an impending fracture here. And this is what it looks like. The right side doesn't light up, right? Because there's no inflammation. It's already broken. It's no longer under stress. It's the left side that lights up. And again, what you can see on the left side versus the right side. So his symptoms match? Yeah, they're perfect. He was playing, right-sided stress fracture, boom, it broke. That doesn't hurt anymore. It's the left side now that's loaded, and it's overloaded over here. Okay. So conclusion, we don't have to conclude anything on that one. We know it already. So what is it? A 62-year-old male, standing walking pain, came on insidiously, 80% right lower extremity, worse toward the end of the day, relieved by sitting, no pain with sleeping. Probably stenosis, maybe lateral recess or central, we don't know yet. But that sounds like right. So what do you see here? A very slight slip right here. I mean, not imperceptible, but there's about a 2-3 millimeter slip over there. Would you expect a guy over the age of 60 to have this? Yeah, remember statistics, 1 in 5 guys, 1 in 3 women. So a slight slip, degenerative slip. Slip is caused by, we know, bad facets. What can this lead to? Lateral recess stenosis. Look at the right facet versus the left facet. You see the fluid in there? You know what that means in an MRI, right? What happens to him when he stands up? That facet is going to sublux forward because right now gravity is pulling it back. What's going to happen to the lateral recess? It's going to get jammed. It hurts when he walks. Have Dr. Evans, friendly, local, and pain guy, put an injection in there. Most likely he'll be a happy person for a period of time, I hope. Okay, 32-year-old male, right lower extremity pain. Look at the pain diagram here. 80% right SI pain, 80% here, 20% in the right leg. Aggravated by sitting, better with standing, can't tie his right shoelace. What's going on? He's got an HNP, probably, right? And probably looking at the diagram going down to where? What's the level probably? L5S1, because it goes down to the bottom of his foot. Now let's see if I'm right or wrong. I don't remember this one. So x-rays demonstrate no list, no collapse, but narrowing of L4-5 and 5-1. Remember, measuring the heights, you get to here, this should be the thickest disc in the body, and that disc is thicker. So it could be either one by looking at the x-ray. So what does he have? He has a tear at 4-5, but he has a herniation at 5-1. And it's at L5S1, compressing the S1 root. I mean, you can get this information 95% of the time, know your diagnosis. Don't even have to do an exam necessarily. Okay, poor gal, I've been beating up on her all weekend. So she can't walk more than 70 feet without upper low back pain ache that stops her. Flex forward, bent knee, hyperlordotic. I'm sure you know all 6 things that can cause this deformity, right? We won't spend our time, but antalgia, degenerative disc, flat back syndrome, spondylolisthesis, facet pain, hyperkyphosis, hip knee flexure contractures, and hamstring and gluteal weakness. So here's history of low back attacks, low back pain only with flexion and impact. Had a microdiscectomy at L5S1 4 years earlier, no leg pain now. What would the MRI show? What's going on here? Poor man's MRI, remember? Discs should get thicker. 4-5 is not as thick as 5-1, so that's going to be a degenerative disc on MRI, but look at 5-1. Number 1, there's no disc height, and number 2, he's had a microdiscectomy, so that disc already pushed some fragments out. So what are you going to see? You're going to see, again, L4-5, interestingly enough, is a degenerative disc. We saw that. 5-1 is just starting to develop some modic change. But if you go to the right, let's go back. This is the center of the disc. See that? Center of the disc does have a little bit of modic change, a little bit of fracture, but doesn't look too bad. But if you go to the right side of the disc, significant modic changes because he's collapsed unilaterally. And that can cause, this is the rare case that modic changes can cause localized right-sided back and sacroiliac pain. So, which one of these two needs to be fixed? No, is this the one? Okay. So does this patient need to be fixed? Look at this. A grade 2 degenerative spondylolisthesis with sclerosis. Do you see that? That's number 1. Number 2, an angular rotary collapse with a slip here. Which one needs to be fixed? What's that? This is a leading question because one patient has pain and one patient has no clue they have this disorder. So again, you have to make sure they have symptoms, and the symptoms have to be bad enough to do something. So this is the one, the second one has symptoms, the first one doesn't. This is a rotary listhesis, failure of that facet. And the first patient is a patient I've been following for 20 years without a change in slip or any evidence of low back pain or radiculopathy. So it's symptoms. Sometimes you can look at something and go, oh my God, and it's asymptomatic, and you leave it alone. So we won't bother our time with that. So this is a guy, or was it a gal? I think it was a gal, I'm sorry. Low back pain, increasing over time, pain with flexion, loading, and impact. Pay for it later pain, and stopped all activities. What is it? It's isolated disc resorption, or I like Dr. Gill's idiopathic disc resorption. So look at the level. The rest of the discs look pristine. This one is incompetent. Look at the inflammatory changes in the bone. This is what scan is this? You have a choice of T1, T2, or stir. Stir, no fat, right? White water. Versus this one, which is a T2. Good, you guys are getting it, this is good. So, patient has mild low back pain only. What's going on at L3? Anything? And this is an older patient, probably, I think, I don't remember, but 50 or so. What's going on? There's a white signal. So this is a T1 or a T2? This is a T2. And so you have white signal in T2. This is also a T2, right? Water white, fat white.
Remember an easy way to remember that? Water is H2O, T2, so T2 H2, so water is running T2s. It's just an easy way.
I have another one, but I can't mention it.
I know. That's fine. I was trying to...
I'm sorry about that. So this is what? A PAR stress reaction. This guy, you can get him when you're older. So stir images, lights up bright. T1 images, black, right? Because water turns black on T1. So you can get stress reactions in the spine even when you're older. So it's a pedicle stress fracture. Okay, this is a 63-year-old with a stiffening low back ache and type 1 diabetes. What's going on here? Yeah, perfect. You guys are getting it. This is dish. Look at the flowing bone. It occurs, the spine is stiffening. Doesn't have to be associated with pain. In fact, as they get worse and worse, they have less and less pain as the spine becomes stiffer. So it's diffuse idiopathic skeletal hyperostosis, or if you want to get bonus points, for SDA's disease. So this is a guy, crash of a small private plane, complains of back pain, neurologically intact. What's going on? It's a fracture, do you see it, right? Lights up like crazy here. This, does it have a burst component? A little bit, but the reason he's neurologically intact, the canal is still patent. So his current kyphosis is about 10 degrees, and he's maybe got 50% canal compromise. What do you want to do with him? Brace him. Good idea. So this is his x-ray when he left the hospital, and they put him in a fabric brace. Not a rigid hard shell brace, but a fabric brace. What's going to happen to that fracture? 35-degree angulation, because they didn't put him in a regular TLSO brace. So collapsed at 35 degrees, and now he needs to be fixed. So bracing is important. 68-year-old patient, mild fall, complains of low back pain, no neurologic findings. What other images do you want? That's what you're looking at. A what? CT's not a bad idea, but you're missing something here. What's that? X-ray is very helpful, but the big image you're missing is the stir image, because here you have water black at T1, water white at T2 with white fat, so you're not seeing the stir image. And there's something possibly going on here. To me, that looks like a little fracture. So here's your stir image. And there's the inflammation in the bone. This is a new fracture. So does he need a big brace? What if I put him in a TLSO? Is that the right brace to put him in? Why is that the wrong brace? Exactly. TLSOs increase L4 to S1 pressure, so it's the exact wrong brace to put the guy in. So you have to put him in a hip spica, but this is mild. I would just let him go. Just make sure he doesn't start running and lifting weights until it heals. So this is just a little bizarre. A patient was fixed at L4-5. This is years ago, did well from that. He has pain with standing in the right hip, increasing with stairs and crossing legs. What is it? This is an interesting one. The hip looks pretty good. I mean, most of the time, increase with stairs and crossing the legs, I'd start to say hip. But in this one, do you see the angular collapse when he stands up at L5-S1? So he's got dynamic foraminal stenosis. So if you don't have a standing x-ray, you're going to have issues. Okay, this is a patient who has neurogenic claudication symptoms, but MRI does not note stenotic canal. There is a degenerative slip. Let's look at the MRI. The canal is open. Canal is reasonably open. Why does he have neurogenic claudication? Exactly. He's laying down. Look at the gapping of the facets. That's probably 7 or 8 millimeters on each side. That thing slides forward. What do you think happens to the canal when he stands up? So it's important to understand when you're reading a radiologic evaluation by a radiologist, they're not going to say the canal has severe stenosis. So you have to know what you're looking for. So look at the spine alignment on the sagittal films. Okay. Has right hip pain with walking, cannot sleep on the right side. Look at that. If you get a very close up here, do you see the little fragmentation in there? That bursa is calcifying, and that's exactly what it is, trochanteric bursitis. Okay, what are these white marrow changes here? Who said that? That was perfect. Altitude. Red and white marrow changes occur with people that live at altitude, and it's benign condition. Versus, let's see, you can't see it well there. Okay, we'll move on. So 40-year-old male with intermittent, incapacitating low back pain. He has a catch on flexion, extension, range of motion, no evidence of radiculopathy. Pain does not radiate into the buttocks when the back becomes severe. 50% low back, 50% upper SI. And it occurs only a catch on flexion, extension. Low back attacks 2 to 3 times a year. Let's take a look. So what is it? Chronic low back pain increasing over the years. So we look at the discs. Yeah, they're narrowed. Okay, I don't see anything going on here as far as rotation or angular. Pelvis isn't level, so draw a line across. He does have a short leg on the right, as long as both knees were extended. If you have one knee flexed when you're taking an x-ray, you're leaning, so you have to be careful about that. So use your disc measurements, and you can see L4-5 should be the thickest disc, and it's now 10 millimeters, and 5-1 should be 12, and it's 7. So he's got degenerative disc disease, or what I like to say, CBS, crappy back syndrome. Okay, 66-year-old male, buttocks pain for 1 year. Bilateral buttocks pain with standing becomes worse the longer he stands. Sitting yields pain relief, can't straighten up in the morning, can bicycle all day but can't stand up straight after a day of riding. Stenosis, nice job. So this is what his spine looks like. You see he's got disc wear at 4-5 and, I'm sorry, this is an incarcerated disc. That's 5-1 and 4-5. And when he flexes and extends, aha, let's go back. Look at the alignment here. You wouldn't look at that and go, he's got an instability, would you? But when you flex him forward, you see the slip? And extension, it recorrects. So flexion extensions are very important films. And he's got neurogenic claudication for a degenerative slip, asymptomatic instability, and central stenosis. His facets, look at the facets, look at the ganglion cysts forming in the canal. He has dynamic stenosis. One more, I think, unless you guys really want to go on for more of this. Low back pain for 5 years, increasing over time, pain with flexion loading impact, pay for it later pain, has stopped all activities. What do you think just by looking at the x-rays? IDR, look at this disc, right? And that's what you see. Easy to find. This inflammatory change, again, patients can present with this and have no symptoms. But if you see this and it fits with all their symptoms, it's isolated disc resorption. Questions? Yes, sir. Every single, I get it with my breakfast, lunch, and dinner. Absolutely.
So you do AP lateral obliques?
No obliques. I never get obliques because most of the time you're going to have an MRI with you. So you're going to look at the MRI and that'll give you information.
But these are people that are coming to you with images already?
Even if you have images, if you have AP lateral and 2 obliques, you'll get a flexion extension in the office.
So maybe even the pelvis, right?
Yeah, exactly.
Is
You
that,
see the hips and...
oh my gosh, I can't tell you how many times we have that overlap. You know, they come in for low back pain and they've got a really degenerative or cam type lesion in their hip. What about when they say, Doc, you think I should get a standing MRI to help us figure it out?
Worthless, in my opinion. Standing MRIs are done, you have to understand the acuity of the machine has to do with the strength of the magnet. The new standard of care is 3.0 machines. Cervicals can get away with 1.5s. Most of these magnets that are standing magnets are 0.7 to 1.0. In addition, an MRI is like an old-time Civil War daguerreotype, where you take a picture and if somebody moves, they look like a ghost. The MRI is the exact same way. And if you're standing, how are you going to keep still enough in order to get an image? You can't. So the images are terrible. And if you use flexion extensions and you compare to the MRI, you can get it every single time. But if you get a crappy image that you can't read, you're going to miss something. So in my opinion, I don't like them at all.
Well, they're oversold pretty hard, I think.
Yes. Well, you know, if you have a product, you want to sell it, right? Other questions? Wow.
I have a general question.
Yes.
In terms of, I think this is the wrong way, but how do you know when you're dealing with this
What was the question?
Because
That's a great question.
you know, you're looking for develop a bit of close or sometimes, like in some patients, but you know, when you're treating like that.
Right. Well, part of it is word of mouth, but unfortunately that's not necessarily the best way to do it. The question is, how do you find a good spine surgeon? Well, can you ask them? How many spine surgeons are going to say, oh no, I stink. You don't want to come to me. Obviously, every spine surgeon is the best one you've ever seen. And there's an old saying, if you put 5 spine surgeons in a room and ask them a question, you get 10 different opinions. So, but in general, good spine surgeons, go talk to them, get a feel for them. Do they jump on everything that comes into the office? There are some guys in Denver that I see when the patients come up after a consultation, and they have 15 different things that they need fused or fixed, and they really don't need surgery necessarily. You know, does the person take the time to talk to the patient and talk about expectations? What's the success rate for disc surgery, for microdiscs? Could be close to 95%. That still means that 1 in 20 patients aren't going to have the result they want. What's their success rate for fusion? Are they realistic? Are they willing to educate the patient? Are they willing to spend the time? I will go through my epilogue. Hold on, because this might be helpful to you.